Hi, everyone. We are here at the podcast Docs In, where we tackle important health topics in an easy to understand way, inviting experts in the matter that will try to untangle um, the issues with the matter that we're talking about today, that is going to be obesity. This is Carlos Abril. I'm a general surgeon and bariatric surgeon, and we've been here at Cleveland Clinic Abu Dhabi for 10 years, almost 10 years here. Time flies.
Very fast.
I'm here with two friends, first of all, and two colleagues. On my left side, ladies first,
Of course.
Dr. Safa Hegazin. She's an internal and obesity medicine doctor, consultant at Cleveland Clinic Abu Dhabi. She's managing obesity in medical approach. And on my right side is my friend and colleague and my director, Dr. Javed Raza. Javed, welcome.
Thank you, Carlos.
That has been working here as a director of the unit for 10 years.
Yeah, we came together.
Before jumping in and having this chat today, I would like to ask you in one sentence, what's the biggest misconception about obesity?
Well, I would say defining obesity as a lack of willpower and asking patients to move more and eat less.
I like it. I'm relieved. No.
And Carlos, from a surgical point of view, the biggest misconception is that surgery is always the last option. It can be last option in some patients, but in some patients with significant diabetes or severe other diseases, this should not be the last option.
You are strict. One sentence only. I like it. So now that I'm relieved, because obesity is not a problem of willpower. I don't know if it's a calorie in, calorie out. I need to work out more. I need to eat less. So it's obesity, Dr. Safa, a lifestyle issue, or we can really consider obesity as a disease?
Very good question. Well, obesity is a disease, and it's a chronic disease and involve a complexity of many things, including hormonal, psychosocial, physiological, and genetic factors. It is progressive, meaning that it will get worse with time if not treated. And it is relapsing as well, meaning if you stop treatment for this disease, it will come back. And all of these define any other chronic disease like diabetes or hypertension. So for that reason, it is considered as a disease and is a risk factor for many other diseases like diabetes and hypertension and liver disease, sleep apnea, and long list of other diseases. And it is definitely not a lifestyle.
Good point. More relief. Javed, regarding the surgical approach to obesity, how do you consider those risk factors linked to obesity? How those factors affects the surgery itself?
Excellent question, Carlos. I think it's very helpful to understand that the obesity is a disease. And so we have many ways, means to treat that disease. And linking other disease processes with obesity is important because the treatments that we offer, and I would talk more about surgical side and Safa would talk about the non-surgical side, that these treatments, these operations not only reduce weight, but they significantly and dramatically improve those diseases. For example, diabetes, half of our patients, or more than half of our patients, they leave hospital even without insulin. So long before weight loss, these other disease processes get changed and improved. So when I look at a patient in the clinic who comes for a bariatric operation, I'm not looking at the weight loss only. I'm looking at improving their health by treating the diseases that Safa has been trying to treat, their diabetes and controlling their diabetes, but with this treatment option working together, we can improve diabetes, blood pressure, sleep apnea, reflux problems, joint problems.
Yes, definitely.
So I've been suffering from obesity for many years. I try to do my best. I felt guilty. I try diets, all the diets in the world. I try to do sports, and I can achieve things, but then I gain the weight back, and now I'm trying to do something, right? And my question is that I'm a patient suffering from obesity. I need to come to see you both, and from a medical perspective, what would be the solution? Because we need to talk about solutions for
Right.
obesity. First, do we have a solution? Do we have a magic bullet, or it's something that we need to invest, like an investment in long term?
Right.
How's the approach from a medical perspective? That now you know that there are a lot of trending topic with the new GLP-1 agonists, this kind of medications, availability, who can use it, who can't, how good or bad they are, what to expect, those kind of things from a
Right,
medical.
right. With this story, we hear a lot from patients. They've been struggling with weight for most of their life. They've tried every single diet on the planet. They would lose the weight and then that would come back. And we've seen also that in research. So when they come to us at Cleveland Clinic Abu Dhabi, we can offer them multiple options, almost all the options, medical and surgical. So we look at the patient, and one size doesn't fit all. We try to discuss with them, look at their past medical history, see what they need, where they want to get, if they are open to discussing medical, surgical, or combined. From my side, I take care of the medical part of managing obesity. I offer medications. We have in the market almost 6 or 7 FDA-approved medications for weight loss. The latest one that we've been using nowadays are they're called in the street the injectables. They're under a family called GLP-1 receptor agonists. And they've been shown to be very efficacious, the latest one at least, in reducing the weight. And the main thing that they do, they decrease the appetite. And at the end of the day, that person would eat less calories than they burn. And eventually, they will help them lose the weight. It helps a lot with the food noise that the people struggle with and craving for food. So also when they eat, they have something called early satiety, meaning that they get full early. They're not able to eat big portions of food. And these medications, of course, they come with side effects. We always explain the goods and the bads of these medications, and we guide the patient through the journey of deciding what they want to do for themselves.
I want to go to the surgery side. We're surgeons. We know that when we do the surgeries, we try one part of the surgery is to reduce the amount of food, right? But I want to highlight something because I think there's a misconception as well that either I do surgery or I go for the GLP, I want to keep eating the French fries, the chips, the burgers, KFCs, this kind of things, because I think we're forgetting about, because when we're talking about diets, I think people think that you have to eat broccoli only, but I think we moved from, in the past, people eating food. Now we have a problem, we don't understand what food means. And we're eating things that are edible things, that they are not food. Because if I'm using GLP, or Dr. Javed, that you do a surgery on me, if I do a sleeve, I think that is much more important because I cannot eat that much, that the food that I eat is real food that can provide me with the minerals, with the nutrients, with the vitamins, right? So many people, they come to you and I want to keep going to McDonald's. And
So, Carlos, you and I have spoken about it many times before, over the last 10 years. Our dietary habits have drastically changed in one generation from
Completely.
food that we could identify, which we could pull out of the ground and eat, to now children who have never seen the source of the food. So this has drastically changed our relationship with the food and partly price that we are paying as a human race to this change. In addition, our physical activity is reduced. So combined these factors, I think one important thing that while Safa was explaining, that once your weight becomes beyond a certain point, then the regulatory mechanism in the brain is like a thermostat of the temperature. It sets to a higher level, and whatever you do to reduce your weight, the moment you stop that effort, like a diet, then the thermostat pulls it back and you try it, and this happens even after surgery.
Right.
And that's where we all, when we sit in our meetings, we discuss that the patient needs to be supported psychologically, physical environment,
Right.
family structure. That's why a multidisciplinary team plays a key part in this.
Absolutely.
So, Safa, what do you advise to your patients from a food perspective?
That's very
Apart from
important.
the
Very
medication.
important. Very important. So we've seen in the study that lifestyle by itself is very hard to lose significant amount of weight with lifestyle. Have
You tell me.
have someone tried it and worked out for him? Yes, but rarely. And a lot of people find it very hard to have a sustainable, strict life to maintain that weight loss. On average, in the studies, we've seen between 3, at best 5% of weight loss. But when you combine this with medications or surgery, we can achieve significant amount of weight loss that person can improve his quality of life and improve all the health issues that he or she is struggling with. When it comes to nutrition, I think the word diet triggers something uncomfortable in a lot of people's mind because that means that they have to be strict and eat this and not eat that. And I think we have to focus on eating healthy more than anything else. And I always explain to the patients that the grounds to build a good lifestyle is to have a good lifestyle. And that includes food, healthy diet, the type of food, the amount of food, managing stress, sleep, exercise, all comes together. And from there, we can build on it. So definitely nutrition is one of the things that I discuss with my patients prior to actually offering medications.
And in that, I think one person cannot look after all aspects of this complex disease. So our dietitians play a key role before surgery, before medical treatments, through those treatments, and after the treatments. And it's very difficult to change habits. We all know that. And that's why this is a chronic disease, because we have developed habits which then further increase the obesity. So changing habits and behaviors. So we gradually work as a team, all team members are giving similar message to the patient and supporting the patients in gaining that small incremental changes in their life, plus the medication or surgery can then enhance all the outcomes that we're looking for.
I think that's the secret. Small, sustainable changes. Doesn't have to be drastic. Sustainable is the key word, I would say.
But you brought up something really interesting, that everybody, if you ask somebody outside in the population, they're going to talk about, even doctors, right? They're going to talk about food, exercise, right? But you brought up something really, really critical that it's very difficult to meet, to reach to our patients when they're in the clinic. Sleep.
Mm-hmm. Oh, yeah.
That's critical, and I don't know how you do that. Because population usually, there are young people, they want to go to bed late or early in the morning.
Yeah.
And then they wake up very late. So it's not only about the number of hours, it's the timing of your hours and the way you go to bed and the environment. How? Because we have dietitians, we have nutrition. You said that we need to target this from a different angles, right? But the sleep could be something that we are missing a bit. What are your opinion about that?
Definitely. Absolutely. We undervalue sleep in our community. People, they don't think that we actually need 6 or 7 hours. If they can function in around 4 hours, they think this is okay and I can kind of get away with that. Studies have shown, this is studies, the lowest amount of hours and the poor sleep. So quantity and quality of the sleep is related to weight. So if you sleep less, and even if you sleep with poor sleep, your weight's going to go up. So we have to tackle that as well.
I think that's very important topic, Carlos, that you brought up, because as human beings, we are designed in a certain way with our hormonal rhythms at night and day are different. So if you sleep late, you tend to eat late as well. And the effect of those calories middle of the night is far worse than if you eat those calories about 6 in the evening, because your hormonal mechanisms make it difficult for late night eating to digest and utilize that. So sleep hygiene, this is a terminology which is very important, especially in younger patients that they come to us. One of the things that we ask them, what time do you sleep and how many takeaways you order late at night? And I think we can provide treatments at the last end of the disease when patients are severely obese, but this is a larger societal problem as to how our food consuming habits, our access to food, types of food has changed. So I think we can cover that in another topic. I love to talk about
Yes,
that.
yeah.
But
That would be great. Yeah, there
yeah.
are a lot of it. We dig. This can last for hours,
Yeah.
right? So I went to see Dr. Safa, but I'm a patient, so you're Dr. Safa to me, and Dr. Hegazin.
Safa's fine.
Okay. And then you treat me. I tried to change my lifestyle, and I did a bit. And I was using one of the GLP agonists. I don't want to give any brand or any name. And I was doing fine. I've lost, think about it, 26 kilos with hard exercise, eating healthy, because I don't like the word diet. And I talk to my patients all the time, the word diet will not come out from my mouth.
Right.
It's eating. So we're forgetting about eating food, real food, not eating the other things that we're eating. But then, I don't know, life, calls, things like that, then I gained not only the 26 kilos, I gained 30 kilos after your treatment was good. And then I decided, I'm done. I think I'm going to go for surgery, which is a bad thought, as we said before, that is not the last resource. So, Javed, if I go to your clinic, what kind of surgeries are you going to offer me, and how do they work?
Thank you, Carlos. I think you could have answered this question, but now that you've asked me, broadly speaking, the type of surgeries are one that reduce the amount of food that you can eat, so we call them restrictive, and the one that decrease your body's ability to absorb the food, so they are malabsorptive. So the commonest operations which are done and people are familiar across the globe is sleeve gastrectomy, where we surgically remove majority of the stomach and leaving a small sleeve of the stomach behind. Second group of operations is gastric bypass. So there's a classic gastric bypass and there is mini bypass or one anastomose gastric bypass. In this second operation, we not only reduce the capacity to eat, so the patients eat less, but also we change the internal connections in a way that the food that patients eat, they absorb less of that. They do not absorb all the food. So a combination of ability to eat less and ability to absorb less then results in a significant weight loss. And if the patients have made the changes to the lifestyle, which is a regular physical activity and eating appropriate diets, then they can maintain this weight loss longer term. And here I just want to bring one thing that I commonly talk to my patients, and I say, if you're serious about bariatric surgery, then your day is 23 hours. 1 hour is your investment in your health.
Right.
So you can walk, you can go to the gym, you can swim, you can dance, whatever you like, morning, evening, middle of the night, fit it around your life, but you commit to that, and then we're looking at long-term success.
Very nice.
That's good. So, but now I'm here. I got a good view about the surgeries you're going to offer me, but should I take vitamins for good? Are those medications and I have to take these vitamins forever? And Dr. Safa as well. So if you're giving me the GLP and things, should I take vitamins because I want to lose weight? What do you think about this supplements, right? Because vitamins are not medication, are vitamins. What your thoughts are about vitamins and supplements?
Well, as a standard of care, these medications, we do not require to give multivitamins with these medications. But when I see patients in my clinic, I do a full assessment, including vitamin levels. And if there's any deficient in a specific vitamin, I would supplement that. But as a standard for care, I don't combine them together. If someone would like to take multivitamins on their own, that's fine. Unless there is a specific something that I need to replace. I don't know about surgery.
So I'm just going to give a comment and I'm going to ask you to answer that part of the question. So my comment is that because the amount of food that you can eat is significantly reduced, so that amount will not in its own provide your body all the vitamins. So you definitely need to take vitamins. And I would now ask Carlos, you to elaborate on for how long do you need to take them? And what are the common types of vitamins that you need to take after gastric bypass? And do you need them after sleeve as well?
That's a good question, and probably we can discuss about that. But it's true. So first, every time we do bariatric surgery, there's a kind of restriction. I know that you can see that many people say, no, it's not a restriction. Well, definitely you cannot eat the same amount that you were eating before.
Absolutely.
What makes much more important that the food that you put in your mouth at least has minerals, macronutrients, and vitamins. But because it's a reduced amount, then your body is going to start increasing metabolism, burning fats, and your body is changing. You're going to need at some point a supplement. Again, those are not medications; those are supplement, right? And we usually in our team, because we work as a team, which is really important. I think is one of the great things here at Cleveland Clinic Abu Dhabi.
Right.
That is not that we're working everyone on their own. We're working together, and we agree that we need to give to our patients vitamins. And majority in those malabsorptive procedures. It could be the mini gastric bypass or one anastomosis gastric bypass, the SADI, the transbipartition, but the bypass, those ones that all the tract of the bowel is not used for absorption, we need to increment and implement or supplement the vitamins that we're getting from the food. And much more, like in every place in the world, if your food is not that good.
Right.
Because at the end of the day, let's say you're having a good diet, if you're eating 65% good food and 35 bad food, that's a good average. But you need supplements. Which ones are we giving? So a multivitamin that can include some iron, zinc, cadmium, daily basis. You have to take it. We usually supplement our patients with calcium and vitamin D. It's true that many patients, they struggle because the size of the tablets, habub, the tablets, right? So that's why it's important for us to find as well other sources of vitamins in other presentations.
Right.
And the vitamin B12.
Right.
That's what we're giving to our patients, mainly in the gastric bypass, because the way the vitamin B12 is absorbed, we're bypassing that part, so our vitamin B12 levels could be really compromised. Regarding a good point, because we discussed about for how long. Well, in the bypass, I think for good, for life. It's true that many times you don't have to take it every day, but you need to create a habit that if it's not every day, every other day, and it becomes your habit, like you wake up in the morning and you brush your teeth, that kind of habit in your life. For sleep, which is only restriction, and this is personal view, there's no science behind it, but if a patient is eating healthy, and the ones that they're really eating healthy, they change their lifestyle, let's gonna talk about that, and they're eating healthy, I think the food will, even in a smaller amount, because now the weight is reduced, they can get almost all the vitamins from the body in the sleeve gastrectomy. Of course, if the sleeve gastrectomy patients, because there are patients that they're doing very well, but they are not eating that healthy, I always consider to supplement their food with vitamins.
Right.
And
I do see patients post-bariatric, and I have two comments on it. First of all, the bariatric multivitamins are high potency. So I want everybody who's listening to understand there's normal multivitamins, and the bariatric vitamins are high potency, meaning they have more concentration of the vitamins. And these are definitely needed more for the bypass surgeries. And then the second thing, people get lost in the system, or they get lost and they don't follow up anymore. And then I see them after 4 years of doing surgery. They haven't taken their vitamins, they haven't seen a physician, they have all these symptoms, multivitamin deficiencies, and they need a lot of care. So I would recommend everyone who's doing surgery, regardless if they need or don't need vitamins, just to have the follow-up with their bariatric surgeon or obesity medicine.
That's a great point.
You're right. I think life is life.
Yeah.
And in our experience, 9 years of service at Cleveland Clinic Abu Dhabi.
10.
Yeah, the bariatric service. So the patients come back if they have a problem. And a lot of time patients are doing well. They've lost their weight, they've improved their diabetes, and after a few years they stop coming, and then suddenly we see them after 6-7 years because they had abdominal pain or they developed some other complication. But I think it's important to emphasize that when we designed our program, we kept an indefinite follow-up for our patients.
Absolutely.
And I think similarly for the medication usage, you would like to follow them up long term so that we see what's happening to our patients.
Right.
But I'm a good patient. Dr. Javed did a bypass on me. It's not true. This is
Hypothetical.
I did very well, but unfortunately, because I think I want your opinion about that, there's a chance that I regain weight. And that's what happened to me. I regained weight, but I'm shy and I don't want to go to see Dr. Javed again because he's going to get mad because I gained weight. It worked for a while, but then, I don't know, and I'm blaming myself because I couldn't use it in the right way, the surgery that he offered me. And then I go to see Dr. Safa, and I go to see you and say, can you do something for me after regaining weight, after this bariatric surgery?
Yeah, definitely. I think this is also one of the ways where medical and surgical management come together. I do see a lot of the medical options being used with bariatric surgeon before the surgery to optimize their weight before they get into surgery, or after when they have suboptimal weight loss, they're not losing enough weight, excess weight, and the condition that you mentioned, which is weight regain. I've used it with patients who had bariatric surgery before and had successful results. I think it's a great option for them, but again, also combining with the healthy lifestyle.
So I would say that when initially the weight loss medication came, people almost saw this as an opposing or as competitors, the surgery and medication. The way we look at it as a team, and this is the team sitting here and the other members, that this is synergistic, this is supporting. So this is a complex disease and we need many ways to treat this disease. And surgery is one way, medication is the other way, and in a lot of patients, at some part of their journey, they would use both. As we become more aware of how these tools can be used, I think we can help more of our patients more effectively. So definitely working together is far better for the patient, and multiple options at multiple parts of their journey.
Definitely. I want to bring up that we are not medical against surgery, surgery against medicine. I think this is the point too. We work together and we want the best to our patients. And we have a medical tools and surgical tools that they can work very well to all of our patients.
And Carlos, we sit in the same space in the clinic. So Safa sits next door, and so many times she comes up and asks me to see a patient, and so many times I've seen a patient and I walk into her room and say, can you see this patient? Because the patient can benefit from you. And you, Carlos, you and I have done this many times. So I think this is a dynamic relationship, considering all the options and how they can benefit our patients.
Yes.
I want to shoot some questions, random. I'm a patient and I come to your clinic. Dr. Safa, I have a thyroid thing. What about this medication they're giving for injection to lose weight? Am I eligible for that?
Oh, that's a good question.
Because I have an uncle that had thyroid
yeah.
cancer in the past.
Oh, yeah, definitely. So I would say three things when it comes to thyroid issue and these medications, the GLP-1 receptor agonist. First, if you have hypothyroidism, which means an inactive or low producing gland that is not producing enough thyroxine, you need to treat this to help you with weight loss. So this is one thing.
But it's not a contraindication.
No, it's not a contraindication, absolutely. Second thing, if there's a family history of cancer beside a rare kind of cancer called medullary thyroid cancer. So I'll go in details a little bit because I think this is important. When they did studies on these medications, they found that there is an increased risk of a very rare kind of cancer in the thyroid called medullary thyroid cancer. I haven't seen it yet in my practice. And that's only was seen in animal study. When they did the human study and in the studies on people, they haven't seen any of that. So there is some kind of warning on a medication to say if you have this kind of cancer or family history of medullary thyroid cancer, you probably should have a more discussion with your doctor regarding these medications. Any other kind of cancer, it is okay. It's not a contraindication. Third thing, if you are taking medication for hypothyroidism, meaning if you take levothyroxine for inactive or low active thyroid gland, and you start using these medications and you lose the weight, you have to go back and check your thyroid more frequently because the medication is based upon your weight. So when you lose significant amount of weight, you might need to lower the dose of the levothyroxine or the thyroxine medication.
Good point. Now I'm with you and say, you did a surgery on me and look at me. The extra skin I have, I've lost 55 kilos. And now I cannot look at myself in the mirror because I don't feel comfortable. How are you going to fix that? Who's going to pay for that? Are you going to do the surgery for me or who's the person who's going to do the surgery for me?
I think it's such a practical question. And I was talking to Safa earlier on. When I was in UK, I had a patient who lost a lot of weight, diabetes got better, and after a year, she came to see me and I said, fantastic, you must be pleased that you had the surgery. And she said, I wish I never had the surgery. And I was shocked and I said, why? And she said that she had developed so much loose skin that she's having problems in her personal life. And that really gave me an insight. And now I talk to all my patients about the possibility of loose skin. It is a price that you pay for gaining your health and losing weight. What we normally say to the patients, if you exercise and tone up your body, then it can reduce the amount of loose skin. But if you have enough weight that you lose, then you're likely to develop some loose skin. For some patients, it's not an issue. For others, it is an issue. And the treatment, unfortunately, is a surgical removal of that extra skin through plastic surgery. But if we counsel our patients well beforehand, and now I routinely talk about this to all my patients, and so they know what to expect, they can then make an informed choice and live with that better as compared to if they don't know and they suddenly see this loose skin after 6 months, a year, and which is very distressing. If they have more weight on the tummy, they'll have more loose skin on the tummy. Upper arms and thighs, those are the other areas. There is treatment available, but it is more surgery. And usually the insurance does not cover it. So this is something to consider when you're planning your bariatric surgery.
And how long will you have to wait for that surgery?
So
I can do it 6 months after the surgery, or
it's
better to wait?
Excellent question, because some patients come and say, well, do the operation and also do the plastic surgery to remove it. So when you lose weight, you're likely to develop loose skin, and your body needs to be in balance if you're considering further surgery. And so we say that normally wait for your, you should wait until your weight has hit the lowest part, which means you've lost the maximum weight, and then let your body stabilize. So not before a year to 18 months after your bariatric operation, you should consider skin surgery.
Sounds fair.
That's good. Before wrapping up, reaching to the end, unfortunately, we can talk about this kind of thing hours.
For hours,
And we
yes.
warm up, we can keep talking about that. So, what would you say, both of you, to people listening to us, people that probably are hesitant to come to reach for advice? They're at home and they feel shy, they feel guilty. What would you tell them to encourage them to come to visit Cleveland Clinic Abu Dhabi and our bariatric team, obesity team?
So I would say, remember that obesity is a progressive disease. It means that it will get worse with time. If it's not treated early, it will affect your health more and more through time. If you or your loved ones struggles with obesity, please seek help early.
I would echo that, and I would say there is no shame. It is a disease, and there is a solution available. So don't deprive yourself of the opportunity to improve your health.
Mhm.
And we are here completely non-judgmental. We are here to help you and support you as a team. So please come and see us.
Right.
So this is the end of our podcast. It's been a pleasure sharing this time with you both.
Thank you for moderating.